New Year. Good morning, everybody. I'm going to start with an introduction of Dr. Marcus Stoddard, who did his medical school at Johns Hopkins University, and then he went for postgraduate training at St. Louis University, completing both internship and residency. And they liked him so much they wouldn't let him leave, so he did his cardiology training there as well.
That's right.
He came here as an assistant professor, joining our faculty in 1988. And between then and 2000, when he was promoted to full professor, he became internationally and nationally known for his work in non-invasive cardiology. He has over 200 publications in very prestigious journals. He, again, has a national and an international reputation, currently serving us as the director of non-invasive cardiology, echocardiology, and nuclear cardiology. And he's also the current president of the National Board of Echocardiology. What we know him, though, for is everybody to a T says he is just a passionate, extremely skilled, particularly bedside educator. And I think his all of his research in non-invasive shows how we can immediately use echocardiography to guide our medical decision making. So I think it's very fitting that he present this topic today. Role of transesophageal echocardiography in ischemic stroke. So Marcus,
right.
Thank you so much.
Good, that's my cue. Thank you everyone for attending this morning. And this is a topic that I have always been enthusiastic about for over 30 years. And it's interesting when you get colleagues that are equally enthusiastic, like Dr. Rimmel, who has run the stroke program at university, to integrate this sort of process. And I don't talk anything about CMR, cardiac CT. If there's any questions about that after the talk, I had a couple of slides if there was any interest in knowing how that stacked up to TEE, et cetera, and how that would have a role. But today the focus is on transesophageal echo in patients with ischemic stroke, potentially ischemic stroke. So the breakdown goes this way. There's cardioaortic embolic strokes, there's ischemic strokes, cryptogenic strokes, patients with AFib is what I want to talk about as well, secondary prevention, post-recent stroke, and also in the AFib patient who has not had a stroke for primary prevention, and just bring once again to your attention this device that's being employed, so-called the Watchman, that includes the left atrial appendage. So this is the breakdown of what I want to go over today, and we'll see what we can get through. Let's first talk about the ischemic stroke population. That's 87% or so of all strokes, so that's a big chunk of the patients we see who present with stroke are on the basis of ischemia. And this can be, and of these ischemic strokes, 20% are cardiac or aortic in origin, so cardioaortic embolism. And the importance of that is that's something that TE can image. So 20% of those ischemic strokes is right in the wheelhouse of TE imaging. There's also cryptogenic stroke that we thought to be on an ischemic basis. That represents 30% of the ischemic strokes. So this is after an extensive workup, no cause is found. TE, I think, offers also things for that population of patients. And the other areas of stroke, TE doesn't really have a role. If you look at cervical cranial arterial atherosclerosis, that is another 20% of ischemic stroke. So that patient population is not captured by the TE imaging, or small vessel occlusions. So, but if you look at these numbers, 50% of these ischemic strokes, in potential, TE may offer some potential etiology for that patient's ischemic stroke. And I always like to step back and show this slide, and I have for several years, and it's a composite of the various multitude of things that can lead to stroke, an ischemic stroke. And it's interesting when we think about it, I don't know that we think about it in this full process when we send a patient for a TEE in general who's had an ischemic stroke, but take a look at all the things on this list. And this is what TE can diagnose as a potential culprit for someone's ischemic stroke. I won't go through them in detail, but I'll leave that up just to digest a little bit, some of which I think are very interesting to focus on too. One is the left atrial appendage. We think in terms of the left atrium, this is a very hot area to look at for potential cause of stroke, even when there's no clots there. If there's dysfunction of the left atrial appendage, it's usually or frequently can predict that this is a patient who may have had atrial fibrillation. This is a patient who may have LV systolic diastolic dysfunction or even systolic dysfunction. They both affect the left atrial appendage and may be one mechanism by which you get strokes related to ventricular dysfunction, but ultimately coming from the left atrial appendage. The left atrial appendage is intimately affected by the ventricular chamber and will become dysfunctional and predisposed to clot formation. TE can assess the function of the left atrial appendage. Other things that I've learned over the many years is that there's a natural place of stasis in the heart. One is the superior vena cava, for example. And if you look at that area, you'll often see, not often, but in some patients with stroke, you'll see clots form there. The inferior vena cava is another place for stasis, naturally. And when it's actually more intense, you can have clot formation. So this is a place that transesophageal echo can image very well, and we do that on a routine comprehensive basis for practically all our patients, but certainly for the patients who are being evaluated for stroke, as this could lead to a paradoxical embolus in a patient, say, with a PFO. Interestingly, though, you don't need a PFO to get a paradoxical embolus. Intrapulmonary shunting does occur too. And I'm not talking about intrapulmonary shunt that relates to, say, cirrhosis or some angiopathy. You have natural chambers, vessels that connect the arterial and venous circuits in the pulmonary arteries and veins. And these circuits lead to intravascular or intrapulmonary flow. And they're intrapulmonary shunts, but not in the same extent that you would think about in patients with cirrhosis. But it's a portal by which right-sided clots can make their way potentially into the left side and lead to stroke. The pulmonic vein, there's very little techniques that can assess this on a routine basis, the veins. The pulmonic veins are another areas of stasis. And with TEE, we can look right into the pulmonic veins and see if there's clots there or see if there's stasis there, particularly in a patient that may have concern about a paradoxical embolus. So I wanted to put this slide up to let you know about the various many things that we look at for TE, many of which we will not even talk about today, but I just wanted to emphasize those. Let's look at some of the information that we have about the potential role of TEE in general and its impact in management of patients with stroke and TIA. This is a study, Dr. Dept was a fellow that worked with us for many years, was a faculty member who's moved on and done excellent work. This is a study that we did in conjunction years ago, and we wanted to look at what is the impact of TEE on patients who are sent for TEE for stroke or TIA. So this was all comers in a sense. It was except for non-hemorrhagic stroke. So in 200 patients with non-hemorrhagic stroke, 141 with CVA, 59 with TIA, middle-aged patients, hypertensive population, 90%, diabetics, hypercholesterolemia, 80% smokers because it's Kentucky, and that's a pretty consistent theme, and just a few patients, atrial fib, atrial flutter. So predominantly in sinus rhythm. And in this group of patients sent to guide therapy by TEE or to assess etiologies, we found at least one or more findings on TEE for potential embolic source in 58% of the patients. So it wasn't like you're just finding something 10% of the time, 15% of the time. It was a fairly substantial number of these patients had a potential source of stroke or TIA based on the TE findings. It could be thrombi, stasis that we talked about earlier, and rare patients myxoma, a PFO, and we'll talk about that a little bit more in detail, which of these are pertinent, atrial septal aneurysms, or severe plaque of the aortic arch. These were also potential sites or etiologies for stroke. And importantly, the TE information was being utilized by the providers who were taking care of patients. In 29%, the care or treatment was changed or altered based on the TE findings. So it had an impact in a good percentage of these patients overall. Anticoagulation was started or stopped in 12%. Antiplatelet therapy was started in another 13% based on predominantly the atherosclerotic findings. antibiotics were started or stopped. We sometimes find relatively asymptomatic, other than the stroke itself, vegetations. Because with the guidance of blood cultures and things, these patients were treated with antibiotics as well. And the patient, of course, with myxoma underwent cardiac surgery. So it did have an impact in almost a third of these patients. If you look at the patients who we saw vegetations on, where there is no concern about endocarditis, and blood cultures were done because of the TE finding, 9 of the 21 patients subsequently had positive blood cultures. So as you know, you can have sterile vegetations, but what it shows you is that there can be a group of patients who have vegetations that you're not necessarily suspicious of endocarditis, who may turn positive, and it wasn't just a small cohort of patients, but 9 of 21. So that was the impact of the procedure in that patient population. Frequent findings of potential embolic sources, and the healthcare providers did impact their treatment. This is another study from the literature, and it's from Casonos that was published in 2016. It was specific for the cryptogenic population, the patient where an etiology of stroke was not readily accessible with the routine evaluations. And in this 88 patients with cryptogenic stroke undergoing TEE, again, one or more findings that could explain a stroke were noted in 69%. So again, a similar yield. Thrombus, stasis, myxoma, PFO, septal aneurysm, severe plaque. And some of the things on that initial list are not even on this list that I had listed for you, but also it maybe even embellished this even more. The treatment was again changed in 9% of these patients on the basis of the TEE findings, either anticoagulation, of course, when clots were found, or patients that needed to undergo cardiac surgery or percutaneous interventions was in 3%. So a smaller impact overall in treatment changes in the cryptogenic population, but still a significant number of patients had their treatment guided based on the TE findings. And as you know, that's a difficult population, the cryptogenic stroke population, trying to prevent subsequent strokes because they're at higher risk for it to reoccur. And then the natural outcome, how that's impacted by treatment right now is not particularly known. Here's an example for you. This is the left atrial appendage. You can see this mobile density within this left atrial appendage. That's a thrombus. And this thrombus has high embolic risk potential. So this is a patient obviously would need anticoagulation therapy when the timing is correct. Obviously, there's a concern about hemorrhagic conversion, but this patient would be highest on the list to start the anticoagulation as soon as possible. So we know that's going to be anticoagulated. This may be an AFib patient, but the timing may be stepped up when you find this on TEE in a patient who had atrial fibrillation and a stroke. Notice also the left atrial appendage. These are the walls of the left atrial appendage, not trying to make you an echocardiographer, but they don't contract at all very vigorously. This is dysfunction of a left atrial appendage, and likely why this patient predisposed to thrombus formation. Another thing we can see that's almost as predictive of subsequent strokes is the development of blood flow stasis, which we call spontaneous echocontrast. If you look here, this is the left atrial appendage. Once again, it's dysfunctional, it doesn't contract, but you'll see this echogenic layers that keep developing. This is actually, these are red blood cell rouleau formation. And as the red cells stack up, you can image them on ultrasound. And this basically is a sign of stasis, a potential harbinger of clot formation. So T is a very well suited to look at the left atrial appendage. Other imaging techniques can now look at the left atrial appendage, but T certainly has a superior role in looking at not only the size and look for clot, but also the function as manifested here by spontaneous echocontrast. Take a look at this 3D image. This is the left atrium. This is spontaneous echocontrast developing in this left atrium. And you can see how the TE imaging detects that very readily. And this is a predictor of subsequent stroke. So TE imaging finding this, which you may not see on a transthoracic echo, adds to a potential risk stratification in individual patients for whether anticoagulation therapy will be needed. Other sources of stroke are in the aorta, This is aortic arch atheroma, all these large three-dimensional images of the aortic plaque. There's also mobile portions of it. These mobile portions are actually clots. Most of the pathology studies on these patients have pretty much confirmed that we see mobile debris like this. It's less often to be an actual plaque that's mobile. It's more often to be a thrombus on top of an aortic plaque, possibly one of the mechanisms by which aortic atheroma lead to embolic strokes. So this patient then becomes a consideration for anticoagulation, impacting care. Obviously, aspirin, high-dose statins for the plaques, that's been recommended in 2014 by the American Society of Stroke Association, and also the American Heart Association. But when you find this thrombi, it's going to impact care even beyond the conventional recommendations. This is a patient who may then warrant anticoagulation therapy. And this is really a very good place that TE can image the aortic arch and also the ascending aorta. This is transthoracic imaging. LV cavity thrombi, well seen with transthoracic imaging. Here's a three-dimensional image of an LV apical thrombus, which obviously would have some impact. So these are then findings that are outside the left atrium. We focus very much on the left atrium when it comes to ischemic strokes, but there are things outside the left atrium that also lead, of course, to ischemic strokes. And with the very diverse imaging you can get with particularly TEE, but also echo, these other non-left atrial sources for stroke are readily found with comprehensive imaging. So you can see this very mobile, large thrombus at the LV apex, a dysfunctional ventricle, and an akinetic LV apex. So a patient obviously would require typically warfarin therapy, and the duration of treatment would be dictated by serial echocardiograms in the future. Other sources outside of the left atrium. This is a patient with a patent foraminal valley membrane. This is doing a Valsalva maneuver. This is the left atrium on top. Without the contrast, we give contrast in the arm vein. It fills up the right atrium. And you can see, and it's moving around a lot, but you can see bubbles that will appear on this side, this burst of bubbles that just appeared. It came through a patent foraminal valley membrane. And we now know that initially we were concerned that this was a cause of paradoxical embolus. Initial studies were sort of lukewarm on the topic, but as those studies extended out, which I'll talk about in a second, in a treatment option for these patients, further confirmed that in fact the PFO should be considered in your treatment algorithm in terms of PFO closure in patients who've had a stroke. And then you would see if this is a potential anatomical situation that you could treat. So PFOs then are readily diagnosed with TE. We do provocative maneuvers during the technique. You can use transthoracic echo as well. I'm sure that's well clear to the house staff. But PFO imaging anatomically dictates how you can treat it. Also, the sensitivity is higher with transesophageal echo than it is with transthoracic echo, typically, as you can see smaller structures. Other things outside the left atrium that we've seen, this is a patient who actually presented with a pulmonary embolus and a stroke that was written up as a case report many years ago. And so this is an older image modality, but this is a transesophageal echo. This is the right atrium. This is the left atrium. This is the foraminal valley membrane separating the two atrial cavities. And you see this serpentine density making its way through a PFO and entering the left atrium. So this is what we call, obviously, a thrombus in transit. This is a patient who not only had a pulmonary embolus, but also had a paradoxical embolus, and we caught it traversing the PFO area, confirming this mechanism. And this most likely came from a DVT. Even though a DVT wasn't present on imaging, you could see that the tubular nature of it suggests it was housed in a vein, a leg vein. And then as that embolized, it could have just gone already through the pulmonary circuit and not have caused a stroke. But what happens is interesting pathophysiology. The pulmonary embolus increases right heart pressures. And when it does that, it elevates right atrial pressure. And when it does that, it opens up these PFOs. And then it predisposes for clots that subsequently pass to traverse the PFO as well. So um, um, it is cause and effect in a sense. The pulmonary embolus predisposing to this same phenomenon. So a very interesting case, and obviously would impact care in this patient. PFO closures, and I was alluding to that earlier. Let's talk about that just a bit, because there's been some degree of controversy on how this should be integrated into our treatment of these sort of patients. So this is a study that were done on patients with cryptogenic stroke. They were less than 60 years of age, was the focus. And there's 5 trials here. The 2 earlier trials, the closure one, didn't find any strong results to suggest PFO closure would alter the natural history of stroke in these cryptogenic stroke patients, published in the New England Journal of Medicine in 2012. The so-called PC also had negative results. A large cohort of patients in 2013 was published. And so we were very much concerned that PFO closure would not be an adequate approach to these patients. But subsequent studies that were extended further out, 2017 were published, all in concert were consistent, that there was actually a reduction in stroke outcomes when PFOs were closed. This was the RESPECT trial, the RESPECT extended follow-up trial, because there was an earlier one, the closed trial, and the reduced trial. So now there's a great deal of enthusiasm for the cryptogenic stroke patient, that you're not finding a harder cause for their stroke, who have a PFO, particularly certain types of PFO, that may benefit from PFO closure if the anatomy is suitable for closure, and TE can determine that. This is a RESPECT extended follow-up trial, a mean follow-up of about 6 years. There was PFO closure compared to medical therapy, which could have been aspirin or anticoagulation based. And this was the subsequent amount of subsequent recurrent events, stroke events, 3.6% versus 5.8%. And the hazard ratio is 0.55. And the way I do the math when we talk about hazard ratios, since the PFO closure is beneficial in reducing stroke, if you flip the number inverted, you're talking about 2 times less strokes in the PFO closure group, about 2 times less compared to the medically treated group. The closed trial mean follow-up over 5 years, 0% versus 6%. Hazard ratio was 0.03. If you flip that, you're talking about over 30 times greater reduction in stroke risk. So a substantial reduction in stroke in these patients. And the reduced trial similarly showed that you had a reduction in stroke, probably about 4 times less strokes in the PFO closure group versus just the medically treated group. So we're now, again, enthusiastic about PFO closures. If you did a meta-analysis of all of these trials combined, and this is a composite of the closed, RESPECT, reduced, PC, and closure trial, it came out to be less strokes in the PFO closure trial, PFO closure, 2% versus 4.5% in the medically treated arm. So this was then ample data in 2018 that's once again helped to confirm that PFO closure is a definite treatment decision that needs to be made in these patients. The ones that benefit, perhaps the larger PFOs, 3 millimeters, hypermobile septums, or significant shunting. Here's a saline contrast study coming across the PFO with bubbles entering the left atrium from the right atrium. Just an illustration of what we would consider a potential high-risk PFO. And it's also suitable for a percutaneous closure. Usually an Amplatzer closure device is used with our structural interventional cardiologists that do this. So again, TE helps to guide this, to diagnose this, and decide whether this is an appropriate treatment option. And this sort of gets me on to another theme. I think that when the decisions are made about closing PFOs in patients who you think this could have been a source, it's got to be perhaps a group discussion, at least briefly, amongst us, obviously the neurologists, stroke neurologists, the structural interventionalists, and also the imaging cardiologists. So I think it should be a 3-pronged approach to at least a brief discussion. And I think all 3 components should be in that decision-making: anatomically suitable for it, technically feasible, and from the stroke information, historically, it looks like that would be the source in terms of the stroke neurologist feeling that that is the likely source. So I think it does require a multifaceted approach. Here's what the amplastic closure devices look like. There's two clamshell occluders across the atrial septum. Here's 3D. This is a 2D imaging of it. Color, looking to see if we achieve, there's no patency across it, makes basically achieve your goal. This is looking at the amplastic closure device from looking down on it. And this is the recommendations of the American Heart Association, American Stroke Association in 2014. They recommended PFO closure when you have recurrent DVT present. So there was a very soft recommendation for it. So it needs updating. So we now have 2017 data. We don't need to necessarily confirm a DVT. If all the other factors point to this as the mechanism, then I think those patients, we should go beyond the guidelines here and consider PFO closure. And I think most centers are now utilizing the more subsequent data, and I think we will get an update in the guidelines at some point going forth, if it hasn't been done already. I could not find it in my review of the literature. This is an example of things outside the left atrium that lead to this paradoxical embolus. I alluded to this before, intrapulmonary shunting. This is not a PFO. This is actually flow coming through the right upper pulmonic vein after injecting into a left arm vein or arm vein. And so you see the bubbles finally make their way through the pulmonary circuit and exit into the left atrium. And so the idea is that clots that did not have a chance to get across to the left side through a PFO, if not present, could make their way to the left side by way of intrapulmonary circuit. So we found that intrapulmonary shunting was actually higher in cryptogenic stroke patients. And this is a study that we published as well. One of our residents was involved with this study. And we looked at stroke patients in general, or TIA, and compared it to age-matched controls, middle-aged population. You see the male-female breakdown. 22% of the stroke group had intrapulmonary shunt, and 10% in the control group. PFOs were also higher, 23% versus 17%, and the combined PFO intrapulmonary shunt group was significantly higher when you combine the two, 42%. So this was not an infrequent finding, something that raises the possibilities that this may be a mechanism when nothing else is found. If you isolated that same to a subgroup of cryptogenic stroke patients, or TIA, 71 were noted. Again, 35% had intrapulmonary shunting compared to only 7%. So in the cryptogenic stroke population, this separation between how often you saw intrapulmonary shunt was even greater. So getting us closer to why we may not find other etiologies, while this one is there laying as an explanation. And the odds that this was associated with cryptogenic stroke, the intrapulmonary shunting, was 6%. Once again, emphasizing that this is not pathology. This is natural physiology that occurs between the pulmonary circuits, and it's just more striking in some patients. So this, I'm not talking about finding AVMs and things like that. I'm talking about the regular anatomy that exists in all of us, that these shunts and channels open during certain situations, and in certain individuals are more prominent, and maybe why we see more cryptogenic stroke. But well out the left atrium, this is the inferior vena cava. We see these string clots in the inferior vena cava. It may not show up well, hopefully it does. These are little string-like thrombi in the inferior vena cava. And this is not a person who necessarily has pathophysiology of the right heart. This is the natural physiology that occurs in the inferior vena cava. There's just actual predisposition for stasis to form, where flow just stagnates naturally in the IVC. And you can see here on this three-dimensional imaging, these little dots, these are bubbles. These are saline contrast bubbles. And what it's illustrating is that these bubbles don't want to move around. They want to stick around in the inferior vena cava, or in fact the hepatic vein. So this is just an illustration that naturally the inferior vena cava has an area of stasis. So if there's other things in the mixture, say hypercoagulable state, inflammation, other things, this is going to be then a site potentially for clots to de novo form and could lead to paradoxical embolization. So this is just food for thought. My notion is, okay, to illustrate is that we look at this all the time. So we get a more comprehensive look of other potential causes for stroke when we look outside the left atrium, when we think about other mechanisms, IVC stasis, and certainly clot formation. SVC, the superior vena cava, is it's also a stasis site. If you do TEs, often you'll see bubbles that just sequester there. Normal patients, we're not talking about right heart failure. We're just talking about they just permeate and stay there and persist there. And there's several areas of stasis naturally in the cardiovascular system: IVC, SVC, appendages, apexes of the ventricles. The SVC is one of them. You see this large clot protruding out of the SVC into the right atrium. Is highly mobile clot, clearly a potential for pulmonary embolus. But if we have circuits that connect from the right heart to the left heart, either a PFO, intrapulmonary shunt, a potential cause for a paradoxical embolus for the CNS. You see here another clot. This one is probably somewhat iatrogenic. You can take a look here. There's a black little core around the outer surface of this. Probably was on a sheath or a central line. And as that's removed, these clots sometimes will stay and can subsequently embolize. So we know with this stasis within the SVC, when we put lines in, these are sites that can predispose for clot formation too, and can be another source for obviously pulmonary embolus, but also for stroke. So echo imaging is needed, TE in particular, to look for this in a comprehensive manner. I alluded to the pulmonic veins. This is a three-dimensional imaging looking right into the pulmonic vein. And this little thing flicking around is a string thrombus. And these thrombi can form in the pulmonic veins because this is on two-dimensional imaging. Because just like the superior vena cava, the inferior vena cava is a place naturally for stasis. Bubbles hang out there. It doesn't flow as dramatically, beat to beat. And so with the right other circumstances, certainly if you predispose to form clots for other reasons, you can certainly form these string clots in the pulmonic veins. Obviously, the pulmonic veins directly connect to the left atrium. If you have a site of communication, to the left atrium, they can go directly for stroke formation. So with TE imaging, you don't see this on transthoracic in this great a detail. You do see pulmonic veins to some extent on transthoracic imaging. But we look at all of the pulmonic veins. There's 6, really. There's upper and lower, that's 4. And then there's a ligula vein and the middle vein. We look at all 6 veins on our TE imaging, looking for this phenomenon as well. So, in three-dimensional imaging is very helpful because we can look right down the pulmonic vein as we look for this pathology in our stroke patients. All right, so we talked a little bit about ischemic stroke, embolic sources, cryptogenic stroke, and percutaneous PFO closure. Let's talk about the AFib group in particular, because this seems to be a controversial thought in many one's minds. You have a patient with AFib, they come with a stroke. What's the mystery? Anticoagulate them, if they're not anticoagulate, move on. And I think in general that approach is fine, but there are going to be select AFib patients where even cardiac imaging, particularly TE, may be needed. I think transthoracic is needed in those patients routinely, and in a subset, even TE imaging, particularly if you're trying to look for other non-anticoagulation long-term treatment modalities to reduce the subsequent stroke rate. And that's a patient for particularly primary stroke prevention, possibly even secondary. But these Watchman devices we're all aware of, I'm going to show you some examples of that. We occlude the left atrial appendage, preventing it from being a source for ischemic stroke in your AFib population, and a patient who subsequently can be removed from anticoagulation, warfarin, or a NOACs or DOACs long term. But let's talk about this group in particular. So this is my summary slide for AFibs, just so that this point is not missed in terms of my thought about it. I think that transthoracic is needed in our AFib stroke patient in practically all patients. T in most of them, for the various things we just talked about, things outside the left atrium that can also be culprits for stroke, that embellishes your understanding of that individual patient stroke risk subsequently. And in some patients, even CT and CMR are needed. AFib with recent stroke, they're the highest risk for having LA and LA appendage thrombus. This is why I see a motivation for TE. If you're going to delay anticoagulation because of the risk of hemorrhagic conversion, but you could move that calendar up in a given individual patient, if they had clots in their left atrium, TE will help you make that decision to go sooner with anticoagulation. Transthoracic echo is a useful screening tool to see if you maybe need a TE. The left atrium is normal size. The ventricular function is fine. There's no diastolic dysfunction as well of a grade 2 or worse, which could predispose to left atrial appendage dysfunction. That may be a patient who's going to be fairly low risk unless you're concerned about things outside the left atrium and may not need a TEE. Comprehensive tool, I illustrated that, and also CT, CMR can play a role. Here's why. As you get older, left ischemic strokes occur more often as you get older. This is patients in the 80, 89-year bracket. It's more common for women. And you see that 25% of all strokes in general are related to atrial fib in general. And that rate of which strokes are related to AFib, it goes up with aging. Nothing new to you. But what does this mean? I've seen people say, well, that's not image of the older patient. We know what's going on. When in fact, the left atrium is the high source for potential stroke in the elderly. So this is why I think it's even more enthusiastic to image these patients with TE. The site of the left atrial thrombi tend to be more in the left atrial appendage. 75% on the left atrium in general, or more. So we need to image the left atrium and the left atrial appendage. But also, the frequency goes up with the presentation that you have with your patients. Here are patients coming for cardioversion that we published. 14% had left atrial clots. These are patients who have persistent AFib. 15% had left atrial clots. And patients with a recent stroke, 43% had left atrial clots. So when that patient presents with AFib and a clot, your yield, AFib and a stroke, your yield for finding left atrial and left atrial appendage clot even goes up more. So if that's a concern to make a specific diagnosis in that patient, then you're going to have a high yield. Here's a 3D imaging looking down into the left atrial appendage. You see two clots three-dimensionally with mobility, high embolic risk. So left atrial clots are not found in 100% though. So that tells us that it may be stuff outside the left atrium that led to a patient's stroke with AFib, i.e. maybe a comprehensive imaging with TE may be useful. So also we need to look at what left atrial appendages are predisposed to form clots. Can we do that with just mere clinical assessment? Well, we have the CHADS and the CHAD-VASc scoring system. We know how CHF in this population was almost 6 times more likely to predict clot. These are predictors of clot. Stroke, of course, predicted clot, 4% in our AFib population. And other things like diabetes and LV ejection fraction were not significant in this population. I think that what these results tell me that you have to factor in, obviously, the clinical presentation, but if the TE is going to affect your anticoagulation decisions, the timing of it, the decision to occlude the left atrial appendage, you need a TE. If you're likely to have LV systolic dysfunction, transthoracic echo will show that. That's needed. Stenotic mitral valve, if you notice that on exam or you've noticed historically there's a concern for that, a transthoracic echo is needed. And if you're going to decide decisions about cardioversion, then transthoracic can help. I don't want to belabor you too much with the data, and this is a thought basically that shows how transthoracic can help predict if you're likely to have left atrial appendage thrombi on TE. There's 2 factors here: ejection fraction of the left ventricle and left atrial size. If your left atrial volume index is normal, that's 28 cc's per meter squared, 28 or less, and your ejection fraction is normal, 55%, the chances of finding a clot on TE was virtually nil. So if you have a normal transthoracic, normal left atrial size, and I would also factor in here grade 2, grade 3 diastolic dysfunction, your chances of finding a left atrial appendage thrombus is low. So if that was your mere goal for TE, you probably don't need it. However, if you find a low ejection fraction, say less than 55%, left atrial enlargement, 16% of those patients had left atrial appendage thrombi. So yield goes up. And if you have to specifically confirm that, you would move on to a TEE, because that's your higher risk patient population. If there's a patient you're concerned about anticoagulating, but not an absolute contraindication, a TE then will help to confirm the presence or absence of a left atrial appendage thrombus. So if you have a patient who's CHAD 2 to 4, that's an intermediate group, and there's a relative contraindication to anticoagulation, TE is recommended if the transthoracic is showing a low EF or high volume in the left atrium, and there's this ratio, which you don't have to remember, but we utilize it if it's less than 1.5. So your EF was 40, and your left atrial volume index was 40. You divide it to 2, you got an index less than 1.5. That's the patient's risk for having a left atrial clot goes up, and that's the patient you would consider anticoagulation, but you would confirm it with TEE. Or if you just had a low EF, and also if you had severe diastolic dysfunction. I would add that. That's my own surrogate thought about diastolic dysfunction. Left atrial thrombi are strong predictors of subsequent stroke. In AFib patients, 14% per year compared to those who do not. 5% per year is still high because these patients still have left atrial dysfunction, spontaneous echo contrast, other things. But when you find a thrombus, it specifically increases the chances of having a stroke per year. We published this several years ago. This is an example, once again, of the left atrial mobile thrombus. When they're mobile and large, greater than 1.5 centimeters, it's no longer just 5 times greater. It's 19 times greater compared to another AFib group. So you have particularly teased out a high-risk AFib group from the AFib population in general, 19 times greater of having strokes if you have this kind of finding on TE. And we saw that the yield, 10, 15% of these patients or more will have these clots. So an individual, you can hone your therapy in such a way that you're going to be more aggressive in the treatment of that patient. Again, the CHAD VAS 2 to 4 patient would typically anticoagulate. If you have spontaneous echo contrast, that too increases the risk of having clots in the AFib group. 14% per year, almost akin to having a clot. So very close to the clot stratification. And I'd say about 40% of these patients sometimes will have this finding. So if this is going to influence your decision about anticoagulation or not, then I think then TE becomes an important role. This is a study by Bernhardt. He looked at embolic strokes. This was with MRI scanning of the brain. So with MRI, 17% per year showed that the spontaneous echo contrast in the left atrium had embolic events, an AFib group. When it was absent, less frequent, 4%. So again, just showing that with TE, when you identify this dense left atrial spontaneous echo contrast, it should be factored into your decision making. If you looked at prospective follow-up of patients with AFib who had this kind of finding, you'll see that the death rate and stroke rate was less if you had no thrombus or spontaneous echo contrast compared to the cohort that did. And there could be very rapid development of these events upon the patient's presentation. So early on, the impact could even be huge when you decide to anticoagulate or to use other treatment preventative strategies in these patients. So I won't belabor that. It just emphasizes the same thing. Here's a study by Bernhardt again, a different study. This is dense spontaneous echo contrast. You can see how this almost looks like a thrombus. And sometimes there's a hard distinction. But in this patient, this is also spontaneous echo contrast. So this is the risk of thromboembolism is substantially high. This is patients that have persistent clots. These clots, believe it or not, can persist for years. They don't necessarily go away with just 6 weeks of anticoagulation therapy. The Bernhardt published a study looking at how long it takes for clots to go away. And some persist at 3 years, 28%, 44% at 1 year. And you still had stroke events in that first year, perhaps because these clots persist. So they can persist in the left atrium even over a span of 3 years. So what do you do with these high-risk patients who have clots who may persist? Maybe intensify the INR monitoring with warfarin, maybe a 2.5 to 3.5 instead of a 2 to 3 range. Adding antiplatelet therapy, that increases risk of bleeding, so it's done with caution. Thrombin inhibitors substituting for warfarin, 10A antagonist, or Watchman. So this is the Watchman device that can be placed. It's placed into the left atrial appendage by way of a catheter. It's an oval appendage, the shape, and is a circular ridge-shaped device. And it expands the left atrial appendage. It has a membrane on it, so this will be the left atrial side, this will be the appendage side. Also has these little hooks that once they're deployed in the left atrial appendage, they grab onto the wall, and this part here expands, or is expanded to stretch the appendage to keep it in place. There's a not limited, but there's a range of appendage sizes that this device can fit. If the appendage is too small, where a 21 millimeter device is too big, or the appendage is too big for a 33 millimeter device, that patient is not a candidate for a Watchman. So you need then, of course, imaging by TEE. Here's an example of the Watchman being deployed in the left atrial appendage. It's on the catheter. If you keep looking, you see it's already deployed there, but if you go back just before it deploys, you'll see it actually pops open. They slowly open the Watchman device in the left atrial appendage. Here it is not deployed, and then it's being expanded, opening, stretching the appendage. And what we do at the time of the deployment is look for a leak around the device to make sure that this is a good deployment. And this is what it looks like from the left atrium using a three-dimensional imaging of it. And there's no leak, so we know this is going to be a good result long-term for this patient. Another thing you'll see on TE reports now is the morphology of the appendage. We may describe this as so-called a windsock. Here's a left atrial appendage. These windsocks they sort of look like a windsock. You can see, if you're not familiar with it, it's just a sock that tells you the direction that the wind is flowing. And this is other anatomical ways to look at it: CT, gross anatomy, angiography, endocast. So it just looks like a little windsock. This is the highest risk patient, for, believe it or not, for developing stroke of the appendage morphology. So if you see a windsock, that should also add into the thought process. And we'll give you an example. We'll composite all this information and put the overall risk of stroke per year based on the left atrial appendage function, morphology, etc. So you don't have to do that math. We'll do that for you. But this is another type of left atrial appendage, so-called a chicken wing. Here's a real chicken wing, all the anatomical ways of looking at it, and this is how the T image looks like for the chicken wing. It's multiple lobes with a little prominent lobe that complements the primary lobe. There's a secondary lobe and a primary lobe. This is what we call a cactus, where we have these prominent pectinate muscles. These are not clots. These are muscle bundles sticking into the appendage. Looks like a cactus. We call that a cactus. And then the last morphology, we call it a broccoli or cauliflower, where it just has these appendages look like a cauliflower. So the one to certainly focus on is the windsock. If you look at the meta-analysis of the trials that were looked at to see if the Watchman would do as well as warfarin, and we saw that, in fact, it was just comparable, at least to warfarin, for overall stroke risk over time. And there was less ischemic strokes when you deployed less hemorrhagic strokes, if you deployed the device. And that makes sense because warfarin is going to predispose to bleeding events. What are the indications for the Watchman? If you're at moderate risk for stroke, CAD-VAS 3 or greater, and you have a relative contraindication for long-term anticoagulation management. Patient with, say, prior GI bleed or HAS-BLAT score that's higher, HAS-BLAT 3 or more. That can be a patient that you may prefer to do a Watchman. Also, it should be non-valvular AFib. Patients with mitral stenosis, particularly if greater than mild or prosthetic mitral valves, would not be great candidates because even though most of the clots in general are in the left atrial appendage, say 90% for the non-valvular cases, when you get out to the valvular AFib group, the stenotic AFib group, the chances of actually having a clot in the cavity of the left atrium goes up, still less than the appendage, but proportionally higher than you would see with a non-valvular group. So that if you just protected the left atrial appendage and stopped anticoagulation, you're not protecting the left atrial cavity. So in the stenotic group, and we have done mild MS cases or less with Watchmans, and that's in the literature, but that's certainly a patient that's super high risk for bleeding. Typically, we don't like stenosis because we know the cavity is more predisposed to form clots too in that patient population. But in general, non-valvular AFib who has a CHAD-VAS score 3 or higher. Randomized trials have proved the efficacy and safety of Watchmans compared to warfarin, equivalent for total stroke reduction, superior for hemorrhagic stroke reduction. Also, these patients had a better cardiovascular mortality. That's an interesting finding in and of itself. I don't know the exact explanation for that because it was perhaps related to the fact they have less hemorrhagic strokes, but it wasn't just simply that. So let me conclude here. When we talk about these patients with ischemic stroke, obviously it's a multifaceted evaluation, and with multiple healthcare providers involved in the treatment of these patients, but predominantly on neural stroke population. But we as cardiologists and also as general practitioners and also see patients, for example, with AFib or have had prior strokes, and you want to do secondary risk reduction. I think all components of treatment occur from different healthcare providers that makes this, I think, appropriate for all of us to be aware of. So clinical assessment is necessary. HIT CT, MRI, ECG, chest X-ray, carotid ultrasounds. These are things that are done. I think transthoracic echo should be done in the majority of our patients unless you're planning to do a TEE. If you're planning to do a TEE, we can also, if needed, at that same time, do a transthoracic to supplement the TEE if needed. And sometimes transthoracic, believe it or not, are needed to supplement a TEE. Imaging the front of the aortic root, for example, in a patient with a prosthetic valve, that could be helpful. If there's a high index of suspicion for cardioembolus, I think it's very reasonable to start directly with a TEE. Why? Much more comprehensive. We're not only going to look at the left atrium, the left atrial appendage, LV systolic and diastolic function. We're going to look at the pulmonic veins. We're going to look at the IVC. We're going to look at the SVC. We're going to look at the areas that otherwise, like intrapulmonary shunting, you're going to get that information. You're going to understand the anatomy of the left atrial appendage and trying to risk stratify it independent of other data that you would otherwise not have had. So I think a TE as a first-line modality is a very reasonable approach. You can start with transthoracic. You have a normal left atrium. You have pristine LV systolic and diastolic function, or at least nothing greater than grade 1. And you're not suspicious of AFib, then that may be all that you need. But in those patients who don't fit that category, who started with a transthoracic, then a TE may be needed if you don't have that patient dedicated to anticoagulation management or that you're not considering a Watchman. There is, and this is my final conclusion, and it's a little bit sobering, but it's the truth. Right now, there's no data that I'm aware of that guiding therapy with TE will affect outcome directly. If you have a host of patients who present with ischemic stroke, and you randomize some to TE, some without, or some kind of process like that, do you get a better outcome guiding your treatment based on your TE findings? And when I sit back and I say that, it might be surprising, but there's just very little studies that even looked at this question. And when you look at questions like this in general, there's very little data that suggests that cardiac CT will make a difference or that MRI would make a difference in any of our outcome data. So that's a very difficult set of data to achieve. But I think as healthcare providers, we do. I told you the impact in close to a third of patients with stroke in general, a cryptogenic population, how it's also impacted by the findings. We are, of course, utilizing the information. And the goal, of course, is to improve outcome. We know in patients who can't go long-term anticoagulation, who have AFib, that we can put in Watchman devices. There's data that also shows it's comparable to warfarin and certainly less hemorrhagic stroke risk. So with that, I will conclude, and I'll take any questions.
All right. If anyone has any questions, you can unmute your mic and ask. Also, we've done. Also, if you wanted to type a question in the chat area, we can read that. We can read that for Dr. Stoddard.
If you see me going back and forth, I should have not sat in a mobile chair. I have to remember not to do that.
Actually, we do have one question.
All right.
And it's I'll read it verbatim. It
Okay.
says, my understanding is that sometimes a paradoxical embolism can be attributed to a PFO when the RAP is not greater than the LAP. If so, what is the mechanism?
Great. That's a very good question because you would anticipate that the right atrial pressure must exceed the left atrial pressure to cause the clot to traverse the PFO. And it does. Natural physiology, at some point during the cardiac cycle, the right atrial pressure typically will go above the left atrium very briefly and back down again. But for the most part, the mean pressure in the right atrium is lower. But there is a transient phase naturally where the right atrial pressure is higher than the left atrial pressure just for a brief period of time and then goes down. That's one potential why you may see a right to left flow of a clot. The other thing is provocative maneuvers that occur naturally. You moan, you grunt, you take a deep breath, or you do things that naturally raise the right atrial pressure above the left. Those also occur. So there's physiologic ways that it happens and normal daily existence where it can occur. And so I think that then that's probably partly the reason. And also, if you look at anatomy, sometimes the eustachian valve is a very prominent valvular structure that continuously shunts flow. It shunts flow from the IVC right towards the PFO channel continuously without any true focal increase in pressure in the right atrial cavity per se, but there's a predisposition for the flow to traverse directly in the path of the PFO channel. So when we see that, we'll comment on, too, a prominent eustachian valve. And when you see the term prominent eustachian valve, even on the transthoracic echo, that's what it should tweak in your mindset, that that may be a valve that actually could predispose to flow in that direction, even when there's no right heart failure or elevated right atrial pressure. Thank you for that question.
Marcus, I have a question, but I want to first have a comment and say that I think you've shown us how imaging, they're beautiful images, and how it makes a lot of sense to see a thrombus and then make that step towards, okay, I better anticoagulate, the risk stratification. Your last comment, though, about why outcomes haven't been improved, I wonder if it's because anticoagulation, and you pointed that out, is not a panacea. It's not followed, it's interrupted, and then even in your own, data that you presented, those clots remain. So I think that the problem is we don't know how to anticoagulate, and I'm curious why we don't do thrombectomies more often.
Yes, that's an interesting approach. In terms of your comment about the left atrial clots persisting, there's been some different studies. Some say they can go away fairly quickly if they're smaller clots. And the ones that do persist, they tend to, we think, organize too. We think they become less mobile, fixed, calcified. So maybe that's enough in those ones that persist. And that's why after a year, there was no more increased risk of stroke in that Bernhardt study. Even though clots persisted, they probably organized. So maybe they're protected in that regards. So in terms of thrombectomy, you would have to go through the left atrium to get there. So you have to go a transseptal puncture to get there. I would think it would put fear in the hearts of most interventionists because it's not a stable structure. We've seen situations where the clot's there and then in just a second or two it embolizes, dislodges, and it's gone. I don't think they feel that they can protect the stability of the clot when they're trying to remove it, that they may inadvertently dislodge it itself. We do it on the right side, certainly, because we're trying to prevent pulmonary emboli. We can suck it out with ecos, all these other techniques. I don't know if thrombectomy is being done for the left atrial cavity, like the left atrial appendage. I'm not aware of that. And I know all the clots, whenever we find them in the left atrial appendage, that precludes us from going on, say, for Watchman. Although there's a different device being developed, where it's more like a occluder device, where you don't have to put this cage inside the appendage, almost like an Amplasser device, sort of like that closure device that you saw across the PFO, that you can put right at the ostium of the left atrial appendage and don't have to go deep into the appendage and dislodge clots. So that is being developed, and maybe in patients who actually have left atrial appendage clots, it could be closed at the ostium of the appendage and not disrupt the clot to cause it to embolize and basically trap it within the left atrial appendage. If someone else knows, I personally don't know of any thrombectomies. There may be case reports, and I'm tweaked enough to do a literature search for that particular question, so I'll know next time when it comes up the actual answer. Thank you.
Other questions for Marcus? I've got one more.
All right.
Because very commonly with GI bleeding patients that also have heart disease, we torture each other over timing, because I think also lack of outcome studies. How long do you hold the anticoagulation in an AFib patient with a low ejection fraction who has a bleeding duodenal ulcer? And we're extrapolating, based on some not exact science of how long it takes a vessel to regress in an ulcer. And so we'll go around and we'll say, please don't put them on anticoagulation for a week or 12 days. And we're basing this on like one study in Japan of ulcer regression performed in the late 80s. And I'm not kidding. So
right, I know.
That's always a problem. And we get into trouble when we hold anticoagulation and do invasive procedures on people. Do you have any comments about timing or what we need to do to get our act together there?
That's a difficult subset of patients to confront, one of which, of course, that they have prosthetic mechanical valves. Then we're really, as cardiologists, pushing you guys to let us restart anticoagulation, or at least some form that we can start, test the waters, and stop it if we get into trouble with further GI bleeding. When you take away the prosthetic heart valves and just simply deal with the AFib patient, I think you could almost use the same risk stratification for embolic events in that subgroup that are going to be off anticoagulation. So if you have a low risk, you can certainly go indefinitely. But if you have a high risk patient, certainly someone with a clot, someone with spontaneous echo contrast, a low EF, then you're concerned. And we never push to go any sooner than what we're told from our experts in the GI area as to when we think it's safe. So we do follow your lead as to when we think we can restart anticoagulation. The other thing is I think that the type of anticoagulant may make a difference too, but that's a bit more speculation, so I won't go there. But I would think that the anticoagulation you choose too may be important at the time that you reinstitute the anticoagulation. But tough, difficult. Thank you. Well, looks like we're ending right on time.
Yeah.
And it's been a pleasure to present and talk today in an enthusiastic crowd, and I appreciate all the interest. And hopefully when we re-meet sometime in the future, we can do something different and expand on this topic. Thank you so much.
Thanks, Marcus. Thanks, everybody. Have a great day.
Bye-bye.
Thank you, Dr. Stoddard. Thank you, Dr. Kruger.